But you think about it, everything that we buy that is of value and as an object, we maintenance the living hell out of it. Our cars, our computers, our phones, what the hell ever it is, we maintenance it on a regular thing. What don't we maintenance? The human body.
Welcome to the Men's Health Unscripted podcast with Patrick and Cam.
We're focused on everything on men's health, looking at your emotional, your physical, and your spiritual well-being. You're going to take care of that and make sure you keep on going.
What's going on, guys? It's Pat and Cam, and we are going to defy aging today with Dr. Jason Schottel, from Anti-Aging and Regenerative Associates. Dr. Jason, how you doing today?
Good. Thank you so very much for having me. It's an honor and a privilege. I really appreciate it.
Yeah, man, we haven't explored the men's regenerative space too much. We've touched on a little bit of TRT here and there, just like what are the qualifications, what to do, what to ask for. Yeah. But we haven't really gone into the regenerative space. And I learned a lot just from looking at your website, all of the options that are regenerative medicine. So tell us a little bit about yourself, how you got into it, and then maybe a little synopsis of what regenerative medicine actually is.
Okay. Well, great. So I started out very young. Like I said, my mother raised me. I didn't go to college until I was 21 because I wanted to make sure she was taken care of. So in that time frame, I was able and fortunate enough to play minor league professional football for 5 years. I was also a professional powerlifter. I won a world title, a national title back in 2002. So funny story of how college works. I knew I always wanted to go to college, but after playing professional sports, I know I didn't want to do sports medicine, not orthopedics, but just be like a trainer, sports medicine, because to be honest with you, when we were professional athletes, we're babies. I need you to wrap my feet, carry my bag. Where's my ice? And I'm like, man, I can't spend 4 years in school, tape feet and carry ice. Just can't do it. And it was funny. One of my friends was a professional boxer, not big time, but he's like, you ought to think about and go and be a nurse. I'm like, get out of here. I'm going to be a nurse. He's like, look, man, so you got to remember, this is back in right around 98, 99. He's like, look, man, it's like $25 an hour. It's 3 days a week and you're around hot chicks all day. And I'm like, huh. I'm in Florida. It's hot. I really don't want to do manual labor. Inside's good. And I don't want to work all the time. This sounds like a pretty cool gig. Sign me up. And that's where really kind of my drive. I came out of nursing school. I did a fresh open heart and CVICU, used to recover them and worked in ER. But I realized very quickly that my license was more valuable outside of the hospital walls than inside the hospital walls. And that's where my path as far as education and teaching people began. And then as time went on, it was my big deal because I was the first person to go to college in my family. I always wanted my bachelor's and moving on. Well, our community college turned into a state college. And then one of my clients at the time said, why don't you go back to school with me? We'll get our bachelor's together. I thought it was perfect. Well, one of the physicians I was working with and helping his practice out, he's like, why don't you go back to PA school and I'll give you 30% of my practice? I'm like, well, that's good, but I could go back to medical school and get 100% of the practice. So that's exactly what I did. So I finished my bachelor's. I went to Xavier University School of Medicine in the Netherlands Antilles, came back home, had some stuff happen in life, and I just kind of reevaluated where I wanted to be in medicine. I knew the traditional model wasn't working. I didn't like to be dictated on how to care for my patients, and given the short period of time and making it not personalized, precision-based. I was basically following a logarithm with somebody in a suit and tie who's never practiced medicine who has an MBA. And the only reason I can kind of harp on that is because I have an MBA. I went back and learned the business side of medicine. I'm like, wow, you're just coming up with analytics and statistics. You're not even talking to your people. So at that point, I went back to chiropractic school to learn holistic medicine. I did a PhD in medical sciences with a basis on biochem and physiology. And that's where my just journey of education came on and on and on. And then I was like, well, I'd like to open my own practice and kind of take care of people the way that I was not taken care of. And we hit a storm. I mean, I couldn't be happier. In 5 years of practice, I think we're close to 4,000 patients all over the world. To me, I laugh. I'm still me. I look in the mirror. I'm like, wow, I cannot believe I'm on with you guys right now. I have people, I'm booked out months at a time. I think it's phenomenal because I love to teach and the impact that we're making is phenomenal. I have people with and without insurance coming to me because they trust me. See, trust is the big thing. And that's what my mentors told me. If you do the right thing, people will come from all over the world. And you'll have to pay somebody to count your money, kind of like on the old Rocky Five, which was the worst of all of them. But he said, do things the right way, and you'll have to pay somebody to count your money. I've never got into medicine to make money. I need a living, don't get me wrong, but I'm not going to ever ethically bend corners or shortcut because somebody took the time to trust me with their health, and that's pretty powerful.
I think some important things to draw out what you're talking about here, where you're saying, some nerds in a suit are out there making that algorithm you have to use to treat patients. They're kind of going through, oh, we'll pay for this. For us, we have that the PBMs, the pharmacy benefit managers, the same kind of thing where they're just some nerds in some suit, nothing to do with healthcare, saying we don't like to pay for that. This drug's cheaper. They can get fucked. And then you're like, this doesn't help anybody. What the fuck are you guys doing? So then, like you're saying, that trust is definitely a huge thing you want to build with patients, because if you're able to do what you know to do what you need to do, and not have to worry about all the extra red tape, and then you're able to get to that patient's end goal and they're stoked about it, they're going to be the happiest they can be. They're never going to have any complaints. And the better part is they're going to get healthy. They're going to get better. They're going to operate, perform better. And then, yeah, they may not come back to you because you may have fixed them up to the point where they don't need to see anymore. But honestly, that's the goal. Like, we don't want to have them come back every 5 days. We want to get them good, and then we want them to live their lives.
Exactly. I tell people this. I tell people, think about it, though. Like, we're in the American medical model. I mean, we've all made some changes to it, but we're still in an American system. But you think about it. Everything that we buy that is of value and as an object, we maintenance the living hell out of it. Our cars, our computers, our phones, what the hell ever it is, we maintenance it on a regular thing. What don't we maintenance? The human body. We go to the doctor when there's something wrong. Well, that's like, hey, man, I should have changed the oil. Damn, my motor blew out. Well, you could have done $20 at Jiffy Lube to change your oil every 3 months to avoid the $7,000 or $10,000 rebuild. You follow me? And so that's what I educate my patients. I'm like, look, what we're doing today is like investing. Today is going to pay you dividends. The next 10 years is going to pay you dividends. The payoff is when you're 75 and 80 and you're badass as you were, even better than you were when you were 40 years old. That's what we're trying to do. So how about we come in so that's where I flip the script from a math perspective and analytics. When I see my patients, they see me every 90 days. So what am I doing? I'm collecting data. I'm collecting trends. So I know about you. So you may come to me one time and your liver enzymes are off. Well, if I only see you once a year, is it fibrosis? Is it cirrhosis? Is it Hep A? What are you doing? Oh, you did a heavy leg day the day before, and you're coming off a weekend of week 1 where you boozed it up, so your liver. So what I tell you, no problem. This is what I want you to do. I'm going to give you this little supplement, this little detox, come back in 2 weeks. Let's make sure it goes down. And 9 times out of 10, it goes down. Everything isn't DEFCON 5, but if I see you once a year, what relationship do we ever have? We don't have one. Again, you guys are grown men. If I tell you something you don't want to do, you're not going to do it. So what I do with my patients, I always say, I need your help as much as you ever need mine. Because for me, I have the tools and the knowledge, but you have you. You guys have had you a whole hell of a lot longer than I would ever have you. So for me to think I know more about you is just being arrogant and asinine.
Yeah, that's the big ticket item. I mean, I don't know, I probably have lost count already, but it's so true. Every person we interview, us, ourselves, our friends, guys, don't go to the doctor unless your arm is falling off, unless the pain is so excruciating that you have no other option. And it's really sad that that's the way it is, because so many of these issues can be stopped maybe right when they start, before they get started. It is just so crazy how stubborn men are. And I really like what you said a few minutes ago. You want to be a badass when you're 75. And it's like a little bit of us talking off camera too. You want to add, you don't necessarily want to add years to your life. You want to add life to your years.
Exactly.
And like what we were discussing about how people go to the old folks home, they go to assisted living. I deal with a lot of geriatric patients. It's kind of my wheelhouse. And I realized that America might be one of the only or very few countries in the world that has assisted living. That is, and like, that is fact. I mean, I'm not sure how many countries have it. It's probably more of a Western thing, but to just have this place where we're just like, all right, you're at this age, you're at this functionality level, get the hell out of here. I got kids to take care of or whatever. And so I really appreciate what you're saying is like, man, get those older folks going.
Yeah.
Yeah.
Well, you think about it again. If for them, they want hope, but they have nowhere to turn. You know what I'm saying? And then, like I said, you think about it, you talk about America. I'm not dogging it, but in Europe, most physicians don't get paid when their patients are sick. They only get paid when their patients are well. Well, what a novel concept, right? Maybe if you got paid that way, you take your job a little bit more serious. Because I do daily things, or I'll do every now and again, I'll get on like social media and I'll just kind of like work as an advocate for patients and just people in general, because the stuff that comes out of some of my colleagues' mouths are the most irritating and asinine things. And if the average person said it, you would say literally they were a stupid human being. But since I have an MD or DO or NP or PA after my name, then it must be gospel. I had a couple, just to make your audience laugh. I had an endocrinologist who are literally 25 years behind medicine to begin with, and I will strongly state my case on that. Please don't go endos for TRT. That's just awful, because they don't even barely believe in it unless you have diabetes or something. But my lady didn't need thyroid medicine. But he was like, you have a thyroid issue. And she's like, well, what do I do? He's like, just start taking naps. What are you, 2 years old? I'm a grown adult. I got time. Oh, hey guys, I got to stop. It's 8:00 in the morning. I got to take a nap. I got to have my juice box. I got to take a nap. I mean, then I actually, because I do a lot of metabolic cardiology, I was trained by Dr. Mark Houston out of in Nashville. Tremendous guy. But, there's I can't off the top of my head, there's a specific gene that people don't tolerate statins well. And my patient has that gene. And his cholesterol, he had a heart attack. His cholesterol is good, like 120. LDLs are 49. And his doctor said, I want to put you on a higher dose of Crestor. And he's like, I can't take the statins. He's like, well, you're either going to take the statins or you're not going to be a patient of mine. He's like, but look, doc, I have this gene. Doctor says, oh, that's bullshit. So nice. You just debunked how the hell we're here. Genetic genes. That's what but what we did is, we did specialized testing. And what happened? Yeah, his LDL was 49. And all of us can agree that's fabulous, right? Except for the fact that nobody is running oxidized LDL. He was 100% oxidized. He was at a higher risk for a heart attack with an LDL of 49 than some of my patients with cholesterols over 300, because his arteries were a mess. Myeloperoxidase, Lp(a), L-plaque2, all these were off the chart. So what do? We put him on Repatha, get rid of the LDL. And now he's stable, because remember, we've dropped his cholesterol to 100. So what isn't he doing anymore? Doesn't have enough to make cortisol. Doesn't have enough to make testosterone, progesterone, estrogen. He has no hormones to do this, and you're stripping the fat from the brain. So his brain is shrinking. So welcome to dementia. And then on top of that, you better give him something for ED, because he doesn't have enough cholesterol in his body to make the hormones in order to get a stable erection. But we had to give him the Crestor, because that, like they said, God, that lowers heart attacks all day, right? Bullshit.
I personally hate statins.
Oh, you guys know that's your field. You know that. Thank God you know that. But we write them like there's no friggin' tomorrow. And again, if you're not doing genetic testing, if you're not doing specialized endothelial testing, it's over. You're done. You're old cardiology. And what old cardiology simply is, very basically, is cholesterol and heart centric. But the way that I was trained was vascular biochemistry and cell biology. And I tell people very simply, it's like your house. Think about it. If you have a sprinkler system, how often does the sprinkler system go bad? Very rarely. What goes bad? The sprinkler, the little PVC pipe, or the sprinkler head. Now, if you don't fix those, the pump goes bad. And I tell my patients, if you can remember that stupid analogy, you know probably more of just general physiology than 75% of the old cardiologists. It's tubes and pipes. It's a manifestation of years of endothelial dysfunction. There's 3 finite responses for an infinite amount of insults: oxidative stress, inflammation, and immune dysregulation. If you can grasp those, you save the arterial wall, you save the endothelium, and the heart's fine.
Boom.
Yeah, there's a bunch of studies. I know when we were in pharmacy school, we had a professor come in and was like, high intensity statin is going to lower your LDL by 50%. It's going to be awesome. She was all fired up. And then towards the end of pharmacy school, I start like reading these articles about how statins potentiate diabetes, and anybody who gets on a statin generally has to take more and more insulin. And
just
so I'm
one disease for another.
Okay, so this might be not that great. Like, it's not as great as the lady was pitching.
No, but you know what? And it's like, I learned a lot of holistic stuff, and I kind of bring that in. But you can use. I tell people, I have it out on my desk. I mean, you can use red yeast rice and Metamucil and lower your cholesterol by 20-30%. There's some people we got 40-50% reductions on. It's pretty amazing. And that's what I think my patients, I'm like, look, let's figure this out together. If they have a natural philosophy, let's go natural. But if it doesn't work, then, we always have the ability to force physiology. But let's see if we can get you to change it. If we can, great. We avoided the medication. If we can't, we know then at that point, then there was no other options. And people are much more comfortable once they've explored options. But to just tell somebody, I'm putting you on a statin, this is what we're doing, again, what do they say? And it's funny, like, even when I was in medical school, nutrition, exercise, you aren't taught that. What do they tell you? Go walk. And then you tell them about supplements, they tell you, oh, you don't need supplements. Yeah, you do, because our food has been sodomized. There's no nutritional value in our food anymore. So if I go to Publix or Winn-Dixie or Kroger and pick up meat, I mean, it's like street drugs now. It's cut. How good is the food? Whatever that cow ate is what we're eating, So you need to take vitamins. You need to take supplements to bridge that gap, because it's not like when we were kids, our food was nutrient dense, or our parents or grandparents. Our food now is garbage. No wonder everybody's sick.
Yeah, a lot of this stuff really is a first world kind of problem that we brought ourselves into. One, for early overproduction and underutilization, obviously, but definitely with we have the choice to kind of do what we want in a sense. So we're talking about how the older populations, for the U.S., we have like these care homes and things like that, where we're kind of on the declining side. But then you look at like Okinawa, they have the oldest population in the world. You got these folks living up to 118, 120. And I lived there for 2 years, and you see these folks, they don't look like they're that old, but they're like carrying their produce down the street. They're not driving, they're walking, they have their carts they're pulling. They're working the fields. They're out there putting their work in every day. They're eating their own food. So like Japan's pretty big on not importing agricultural goods. So like everything they have there, they've grown. So it's stuff that they pulled from the field themselves and then brought it to the table. So they're out here living to unheard of ages for most of us. We hear the outliers once in a while, but like not the same way they're living.
Exactly. So I think that's really the big deal. Is like I said, it's kind of, in my world, it's finding the root cause of the problem. I still go back to my teachings. Like I tell people, like when I did nursing, that's everything above, that's the iceberg above the water. Hey, give the metoprolol or give the whatever medicine. Oh, what is that? It's a beta blocker. It can lower the heart rate. I don't know what else it is. And that's not what we were trained. And it's funny, when I went to medical school, it's kind of like the why are we doing it? But the PhD taught me here's the breakdown to the biochemical level of when we do this, what are we activating here? What's downstream in this pathway? If I run an angiotensin pathway, an angiotensin 2 pathway, how do I get it to go to bradykinin so I can raise the AMPK, lower insulin resistance, and cause vasodilation, or raise cyclic GMP? You follow me? How do we do that? How can we use meds to do that? Again, I believe, I'm going to take a guess, but I'm going to use a drug, leothyronine or T3 or Cytomel. Very rarely do people ever write for it. They're scared to death of it. And it's not even standard of care in the AMA as far as diagnosing thyroid. You run a TSH, which isn't even a thyroid hormone. It's a brain hormone. And then you run a T4, which is an inactive form, which is a check, not cash. And then if your TSH is high and the T4 is low, You start with levothyroxine, 25 mics, and you go up 25 mics every 90 days. You never draw a T4, and you literally treat off the TSH, which isn't even a thyroid hormone. Well, let's go to liothyronine. And it was great. And this is the studies we did when I was doing my fellowship training in cardiology. My doctor was like, explain to me congestive heart failure. So you think you're smart when you have this stuff. So here's the physiology. He's like, no, congestive heart failure is an energy deprived heart. Give the heart energy, watch the people get better. We were giving congestive heart failure patients anywhere from 50 to 100 mics of liothyronine every day. You were watching their ejection fractions go up. You were watching the people walk down the hall better. I'm not saying it cured it at all, but it definitely improved them. Instead of giving them DIG, dilators, and diuretics, you gave them energy. Because if you paid attention, the heart doesn't convert T4 to T3. It needs peripheral T3. I'd say 90% of my cardiac patients are on as low as 5 micrograms of T3 every day, not for their thyroid, but solely for their heart and ventricular functioning.
That's really interesting stuff.
So that's kind of what I do. That's where I take the modern, learn about the regenerative, and how can I really kind of take what they've been doing and say, well, look, you can do it this way, but you choose not to because Aetna said you can't do that. Aetna won't cover liothyronine. Yep. Aetna won't do this. You see what I'm saying? And then I'm not going to be a preferred provider because I'm doing stuff that's not on their algorithm. So then my reimbursement rate goes down.
Yep.
Right.
It's crazy. I love it. To me, I tell my patients, I'll always use your insurance any way that I possibly can to save you money, except you're going to pay for my time. I'm not taking your insurance. I'm not waiting 90 days to get paid. I went to school for way too long. I'm going to practice the way I want, and you pay me when we're done. Everything else, you can use your insurance. And it's funny. I love it. You see the doctors get very, very mad because for me, when I started my practice, I didn't have anything. And my mentor said, either you go insurance, you go cash. But if you go insurance, you build up this practice, you can't go cash because what are you going to do with the patients? I'm like, well, this is an easy no-brainer. I don't have anything and I'm broke. So if it fails with cash, I'm right back to where I was. But it turned out, it literally, it's funny. You've talked to my wife more than me. It started month 1. I'm like, oh my God, we're in trouble. I got like a bill for a lab that was like $900 and the rent was like $3,000. And I'm like, oh Jesus, we're in trouble. I'm panicking. Literally the second month she walks in my office and she's like, what in the hell is going on here? I'm like, I don't know. I had manila envelopes to the ceiling, checks everywhere. I'm like, we're in trouble. I have no idea what we're doing and we're busy as shit and it's just me. So within the first 90 days, we expanded. Within the first year, we expanded again. And now, like I said, I take pride of where I come from. I have 15 people who work for me who I give them a job and they can support their families. And then we have almost 4,000 people that we've impacted a community for change. And to me, like I said, I've won right there. I wasn't supposed to be doing all this. That's what I'm saying. I'm so happy. And this is just a win all the way around. I can't believe it. Like I said, every day I wake up and I'm like, wow, this is pretty cool.
Man, that's pretty interesting. We've actually talked to a couple other like different providers in different fields like DPT and stuff who've actually pulled themselves off the insurance model. They came, remember Dr. Kevin, he's out in Orlando and we, met him through a friend of a friend who's also a DPT. And he's just like, yeah, I quit insurance because I can only get my patients to a certain level on insurance. When I go off the insurance model, I can exceed expectations. I can, he's like, I only get so much time on insurance. So I can only spend this much time. That's all I can bill for. But if I go off, they pay me cash. Now I can spend an hour with them. I can spend 2 hours with them. We can do a full diagnostic check on their body and see how they're going and see where we need to progress rather than like, hey, how's it going for 7 minutes? Good. All right, we're out of here. And nothing really gets done. And I can't say I have, private clients that I help them. I'm an advocate for them.
Okay.
And I've gone to doctors' offices, like doctor's appointments with them. And it's like, it was like 5 minutes, guys. Come on.
Yeah, I do the same thing. I do the same thing with my patients. And like I said, you're not going to find, it's not just me. I think it's a paradigm shift, but I do that with my patients. I'm like, look, I'm your advocate. Make sure I'm down as your doctor. If you're in a hospital, call me. You need me? Tell them I'm not talking. I'm like your attorney. Don't talk unless I'm there. Because if I tell you what, man, if you don't have somebody, if you're not in the healthcare field and you're not advocating, you don't have somebody advocating you, you're in trouble. You're in big trouble. You're good. It's sad, because the stuff that like we talked about earlier, the stuff that comes out of their mouths, some of the idealizations, and if you don't know, if you're the guy who works at Walmart and bags groceries, you don't know the stuff that we know. You didn't go to school for that. That's not your fault, but you also shouldn't be hamstringed and railroaded by somebody who's supposed to be looking out for you. That just blows my mind. See, that's where you can see, I get very irritated and agitated with that because they're people and you're not treating them right. It's what benefits you. And that's what one of the biggest things I ever heard and made me laugh is I had they start, now that we're big in my town and a lot of the patients come to me now, but I had a doctor tell a patient sometime down the road, like, well, he must not be that good at what he does because he doesn't take insurance. Oh, you dumbass. The only reason that patients go to you is because they open their goddamn book and you're the preferred provider in their network. That's the only reason they go to you. They have insurance and they come to me. They can use their insurance, but they pay cash to see me. See, it's asinine. That's this old mentality. Well, I do this, so he doesn't. Well, he must not. I'm not good. I have 4,000 people who pay me cash. I may not be good, but I'm doing something right. I don't know. The old man's doing something right over here. So,
and it's a weird paradox for the insurance scheme on that, because the way Medicaid, Medicare, where they work is, they're planning on, if you're taking care of the patients, there's less returns, and then if patients are returning due to like exacerbations of their major conditions, they'll actually like dock payments to these doctors and hospitals and stuff like that. And it doesn't make any sense, because if you were to spend that time originally, the initial appointment, spend that hour, you're going to get them better faster, and they're not going to come fucking back. And it doesn't make any sense why some like peanut pushing nerd is sitting in a cubicle like, oh, fuck T3. We can't give them levothyroxine. We got to only do levothyroxine. And it's because they don't understand, like you said, it's not their wheelhouse. And I feel like every provider should really have some kind of background that's pretty heavy in like biochemistry, biomedical, like not biomedical, but like biomolecular sciences, just because you need to know exactly how this shit's working.
And I didn't either. And we get exposed to it, but like to me, like you have those aha moments in life. Like you get me talking, especially with you guys being pharmacists, you get me started talking about biochemistry and physiology, I'll talk to you for weeks on end. I love it. That's how I tell people why I think separates me, because that's really where I practice. I don't practice at the overall organ system level. I'm at the cellular level. Hey, why are you not making hormones? What's going on at a cellular level? Because what do we learn in school? Cell, tissue, organ system. What do we do in American culture? We work on the organ system by band-aiding and symptom management. If you want to fix the organ system, go back to the cell. Fix the cell, fix the system. But again, like you said, in our model, you don't have time to go to that cellular level. You're just going to stay at an organ system level. But see, when you take, you do what we do and change that paradigm of thought, now we're working cellular. Now to me, when you start pulling genetics, you start doing micronutrient testing where you're opening up the red and white blood cell. When you start looking at DNA, you start looking at organelles within the cell. Now you're really changing the face of medicine. Now you're getting to the root cause. I like to call it precision-based medicine. It's precise. I'm working with your genetics and cell type. So if I'm speaking to two men of the same age, same everything, A is going to be different than B because his genetic and cellular makeup's different. And that's the thing I pride myself. Every patient is somebody new. It's not and again, I'm not knocking TRT clinics. Some are very, very good. Hey, I'm not wrong. I have nothing against capitalism. Some are flashing cash. Give me the hot bodies, the big muscles, and let's do it. But I think, when you really look at why are the hormones low? What is it impacting? How did we get here? How can we solve it? I talk more men out of testosterone and put them on other things because I don't think they need it right now. You see what I'm saying? I mean, we write for a lot of testosterone, but I use a lot of enclomiphene. We get huge results. Not clomid, but we're using enclomiphene now. Huge results. I've got guys walking around with anywhere from 900 to 1,300, and they're producing it on their own. But then again, everybody who knows everything, they go to the doctors, they don't know what it is. What's that medicine? I don't know what that is. Why are you taking this? You see, but yet you don't know about something, but you don't know, but you want to give advice. See, to me, that's arrogant and asinine.
Yeah, to a degree. I mean, a lot of the system is just like, hey, you got this, we're going to slap a Band-Aid on.
Exactly.
Exactly. And this is like some, from my perspective, a lot of times you'll see, men younger and younger are now getting optioned for testosterone. Mm-hmm. And you're like, dude, you're 30. Like, you're not that, you know what I mean? You're not really that old. And it's like, well, why? And their testosterone might be like borderline low. And they're like, well, we'll just get you on testosterone, get you back to where you are. And it's kind of difficult because you put a 30-year-old man on testosterone, they're kind of stuck on it. I mean, for a period of time. And I don't understand why there isn't some exhaustive measures taken, at least first, like, hey, you can try this supplement, try some, medication. We can try a few different things. Let's clean up your diet and your sleep schedule. Right. And
look at cortisol, look at GI.
Yeah. And I mean, I've had young men come into my office, like, I work with older people, but I've had younger guys come into my office. They're like 32 and their testosterone's down. And there's like, yeah, my doc wanted to do this, but I don't really know what to do. And I don't feel comfortable with this because I know it's going to be a lifelong thing now.
Mm-hmm. I've had my youngest, and again, this is what, I mean, again, when you get into this, you don't really, we all learned a lot. We did our schooling, but until we see that patient, that's when it all floods in together. I had a 21-year-old come to me, never taken a street drug, never taken anabolic steroids or anything. Testosterone, 93. 93. And I see it a lot. Again, of the close to 4,000 patients we have, I want to say probably over 35 to 40% is less than the age of 35 years old, who came in with some type of hypogonadism. And a lot of times with that, again, we go through the options. What are we looking for? Because don't make this shit, we all made dumb decisions when we were young, but don't make a decision at 21 that's going to affect you when you're 38. I know you're not married now, but you might find that special somebody and you might want to have kids. So what do we want to do? So like I said, and like I said, it's funny how my practice has evolved. I kind of like on Seinfeld, I'm like Kramer. I fall ass backwards into thing and then it's successful. Like fertility, like I play professional sports and, I'm transparent with my career and maybe didn't make the best choices, but I have a lot of patients who trust me who do anabolic steroids and are athletes. And I'm not going to condone and not going to, put the scarlet letter on them, but I'm going to make sure they're taken care of. I tell them I don't condone it, but let me make sure you're healthy because you're going to do it anyways. But that's what happened. I get guys of our age who all of a sudden are 40-something years old, been on steroids for 20 years, but then they meet a 24-year-old who's the love of their life now, and now they want to have kids. It's like, all right. But the first time I'm like, well, we can give this a shot. So I made a fertility protocol, and the first time I ever did it, we ended up with twins. And now everyone comes to me, athletes and people who have been on anabolic steroids, and they're like, oh, I heard you do fertility. I guess, I don't know, but we've done well. We're probably batting, and some of this stuff, I got to pinch myself. I'm probably over 95% success rate in conception and bringing men who have, and again, this was crazy to me too. Most of the time when I run these, 0 sperm, not a swimmer involved. The best case I ever had is actually a friend of mine who was on anabolics for 18 years. Not 1 sperm to speak of. We took him off of the anabolics. We put the protocol together. In 6 months. He went to over 40 million sperm. Testosterone went back to 800, and his wife is now 20 weeks pregnant.
That's awesome.
It's pretty cool. Like I said, those are options that insurance isn't going to cover, and your doctors aren't going to know, and so you're just screwed. Well, like you said, the typical model to me and what I'm seeing is people are 1 to 2 layers deep. If they get to the second layer, they can't solve it. It's like, it just sucks to be you. Now, what I pride myself and my providers, the way I teach them, I want 6, 7, 8, 9 layers deep. That didn't work. We got this. This didn't work. We got this. Let's go here. It's just kind of like, there's your logarithm. Okay, go here to here. Okay, no, let's go this pathway. See, that's what it's like you guys said. When you understand biochem and phys, you understand human pathways. See, I think when I was in medical school, I didn't pay attention. I just wanted out of biochem. I don't need this shit. Give me the pathology so I can write prescriptions so I can get them. We don't pay attention to it. But then when I got out and did the PhD, I'm like, man, I literally turned into a biochem phys nerd. I'm like, that's it. That's my life. To me, it was the most fascinating thing I ever learned, because that's how you run. You fix that. If you can alter and manipulate biochem, you can optimize physiology and stay free of pathology. See, I don't want to deal with pathology. That's a pain in the ass, just like labs. I hear people come, my primary said my labs are good. Yeah, because there's no reds, but your labs suck. Your T3 is 2.4. That's normal, but you're almost in T3 syndrome. Your testosterone is 350, but any testosterone less than 500 is no longer cardiovascular protective. You see what I'm saying? It's like, oh, but you're good. That's normal. And that's what you're seeing now because of the time crunch. Basically, just look at labs. Look at reds and greens. If it's red, it's bad. If it's green, it's good. No. And that's another one. I can't bore you guys with these details, but like kidneys, I just started thinking about, like, my mom's husband's on dialysis. He's on kidney transplant. How many people are on dialysis, have been diagnosed with kidney failure today based on the old testing, right? Because why? We run a GFR. We don't draw that blood work. That's a calculated rate. And what do we use as the variable? Creatinine, right? Well, that's asinine, because we have 211 different cells in our body, and creatinine comes from one skeletal muscle. So there's 210 other cells that creatinine does come with, and that's what we're going to base somebody's entire renal future on, is creatinine. Well, when I learned from my cardiologist, so what I run on all my patients, if I don't like their GFR, run cystatin C. Nobody's running cystatin C. Run cystatin C. It comes from 210 of the 211 cells. So I think we could agree it's a stronger variable. So when you see somebody with GFR of 47 or 50, you may not use the medication because the GFR isn't high enough. Run it with a cystatin C and watch a GFR of 57 go to 90, 110. So did they have kidney disease? Was that GFR really 25 or was it 55? Did we put people on dialysis way too soon? You see what I'm saying? If you don't run that cystatin C, then you're just shooting at the dark. And I work with a good nephrologist. Like, I'll send, I was scared when you get out of school. I mean, you see a creatinine of 2.1, like, oh shit, this guy, they're done. The guy's like, nah, you got to run this test. It's fine, But I'm saying those are the little things. And it's not that, and the doctors get mad. It's not that hard. Spend time studying and logically think things through and say it out loud. They hate me when I do speeches because I'm like, can you read? Can you write? And can you retain information? Then you can be a doctor. I say it to kids all the time. And they get the doctors get so mad because you think it's such a privileged thing. Again, you're not 7'2". That's God-given talent. To be able to read, write, and retain information, that's a human skill. Anybody can do that as long as you're cognitively ability. Now you have to know, do you want to spend, like we did, 8, 10, 12, 16 years in school? That's the only separation. The only thing I did is because I had nowhere to go. Is back to where I came from, which wasn't good. So I'm like, I will not be beat, and I will go to school as long as I have to go and spend whatever I have to do, because you're not going to ever deny my education. And that's what I did. I just spent 16 years. So I was broke for a quarter of my life. You know what I'm saying? Most people don't want to make that commitment. That's why they're not doctors. But please don't talk down to somebody because they're a mechanic, because you know what? They're a whole hell of a lot smarter than me when I work on my car, right? Which is just what I chose to do for a living. That's what you guys chose to do. You want to be pharmacists for a living. Doesn't mean that we're better than anybody. It means this is what we chose to do for a living.
Just
and that's
our job,
where you get
man.
the arrogance. The arrogance kills me in this profession. And it's nice that I have my own practice. I don't got to deal with their bullshit anymore.
Preach on.
There. Let's be honest, though. Those three things you're talking about, to be a doctor, you don't even have to write that good. Like,
no, I write like shit. So
yeah, like before they write like complete horse shit, you can't read any of it. And nowadays it's electronic most of the time anyway, so if you can type, you're fine. But yeah, like you're saying with ordering that cystatin C, that shit is such a pain, especially if you're like coming from our position, either being a student or being a pharmacist and trying to suggest getting a cystatin C ran. They look at you like you're like completely out of your mind. Like they've never heard of this. Like, why would you even do this? Because I was at a rotation at the VA one time for I think ID for infectious disease, and I think I brought that up running one for a patient. I think with staph, and it was having Danko issues, and I was like, let's go get some statin C's with that, and they were like, why? And I was like, just fucking do it. Like, it's the government paying for it anyway, so who the fuck cares? Let's run this lab and find out.
Yeah. You have like that one, they don't do it. It's like, it's amazing. Like, you don't run it, but then you're not getting the full picture. You're not treating the patient. And see, and that's the one thing I get too. I've always taught my patients to see, like, you get a lot of doctors say, well, I don't believe in this or I don't believe in that. See, first of all, you know as well as I do, you guys more biochem than I had. But what I'm saying is, medicine and science isn't a goddamn belief. It's science. It's black and white, okay? Because my daughter's 13. Her belief in Santa Claus is going to change here shortly. So wouldn't it suck to take care of your patients under a belief and kind of find out your goddamn belief was wrong? So how much wrong did you do your patients because you bought onto a belief? And again, it's not as bad as what it was, but again, literally you can look at your doctor and when did they graduate? So they're still, if they haven't, I would tell people on my student loan bill, probably 35 to 40% of my bill is fellowship and board certification and postdoctoral training. Okay, because when you graduate medical school, if you don't do really any intensive training, you're still practicing the year that you graduated. And then you got some bullshit salesperson who's going to teach you about Crestor and why it's good because they're just trying to make a sale. But you're going to take their information, but they're not going to take it from you guys. When you say run the cystatin C, you're a licensed professional with knowledge. I'm not doing that because the girl who sends me metoprolol, which is a shit beta blocker, everyone tell me I should use this all the time.
That's such a dirty drug. It's such a dirty drug.
It's the worst. I'm like, so they put you on that. I'm like, did you ever ask him for, like I said, yeah, it's first of all, it's not tissue selective. And it's basically, if you take metoprolol and ask somebody, they're going to give you the same symptoms as depression and the same symptoms as low testosterone. But again, now we finally the patent from Bisolic came out. What a beautiful beta blocker to use. It's not, it's tissue specific. It's got vasodilatory properties. It's got antioxidant properties, but it's expensive. Metoprolol you can still get for like a nickel for 90 for you get for 90 days. And it is, like you said, it's an absolute. I look at them like, HCTZ and metoprolol do nothing to help endothelial health at all. And it's funny that when you put HCTZ with any other drug, you decrease that drug's effectiveness by 30%.
You're filtering that shit out so fucking fast.
Oh yeah.
But isn't that funny though? I mean, it's like, I'm going to give you this. Oh, you're on this? Well, that medicine now sucks by 30% just because I added this. And it was like I said, when I treat people, unless they're now, mind you, very sick, but the average person who has a little bit higher blood pressure, you don't have to use a diuretic. I'll put them on a very good ARB like telmelsartan, olmesartan, and I'll put them on a little bit of amlodipine to vasodilate the afferent arteriole so that filtration goes better. If I don't even use a diuretic, get them to lose weight. Lose water or get their pressure down. I use about 5. I'll use 5 of like amlodipine in the morning and use telmelsartan and olmesartan. And it's perfect because the water comes down, pressure's down, but they don't have all the side effects of just blasting them with all these medications.
Right. Funny little anecdote about metoprolol. I'll never forget this. So I had a preceptor towards the end of pharmacy school as a 4th year. We were having like a heart failure discussion and all this. And she was saying, yeah, a lot of your patients, you're going to start, they'll start metoprolol and they're going to feel bad. They're going to just feel like crap. And this is the time you really cheer them on. You say, hey, it's going to pass. It'll be good in like 6 weeks. And I just turned and looked at her and I was like, Rachel, do the patients really get better or do they just get used to feeling like shit?
Yeah.
And she didn't really have an answer. And then the other preceptor was like, yeah, let's move on.
Let's move on.
And I was just like, all right, cool.
But
I hope I don't take that to school now.
But look, but again, it goes back. I use these analogies. Like my attending in GYN asked me again he asked me, Doc, what's medicine? So again, you're young, you're all excited. Oh, well, medicine, blah, 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 blah. All these big, he's like, no, all medicine is what the person in front of you did before you. I teach you this. You teach your students this. They teach their students this. You do the same goddamn thing. But the minute like today we're talking, the minute you say, hey, let's use Bisolic instead of using metoprolol post-MI. Let's use cystatin C and get rid of creatinine in general. Now what you've done is you've changed the trajectory of medicine forever. We're just doing the same thing we've always done. In traditional medicine, what's the thing? If you do the same thing you've always done, you're always going to get what you always got, right? And we wonder why we're no better, because we're just doing the same goddamn thing that's been fed down our throats. You know what I'm saying? What if you have blood pressure? You put them on lisinopril, which is garbage, metoprolol, HCDs. Again, logically, if the ACE receptor is inside the cell, that means the medication has to go through the phospholipid bilayer, except for the fact that lisinopril is lipophobic and it hates fat. And if you're not giving it 2 to 3 times a day, it's pretty much useless, but everybody's on it. I can't figure out why the pressure's still high. So they keep loading up the blood pressure medication. We gotta add a diuretic. Well, we gotta add a beta blocker. Let's put an alpha blocker in. You know what I'm saying? Now this poor person is not even perfusing because the pressure is so low. But there again, what do we do in our office? We check central pressure and peripheral pressure, because same difference. Somebody's peripheral pressure could be, let's just say 140 over 80, which maybe mild hypertension, right? So say your primary puts you on a medication, but their central pressure could be 118 over 75. You're treating the 118 over 75. So you wonder why the person's passing out and tired. They're not perfusing because their central pressure. Again, peripheral pressure, like I said, my pressure's up when I got here because I had to run home to get on because it didn't work. You know what I'm saying? But my central pressure didn't change. Central pressure is aortic pressure. If you're not checking that, then it's not an accurate blood pressure. So you're treating it accurately. But you can't get insurance to cover a central pressure. I bought the machine myself, and I'm the only one, I ain't that smart, but I'm the only person in Volusia County that does central pressure who's not in the hospital. Come on, man.
Yeah, man.
Oh yeah, and that's the big problem. You have like a lot of patients, they'll come talk to you about the medication, and they were just started on something. Their blood pressure was reading 130, 140s, and they come and like, oh, they're on low dose. They're on 5 milligrams of Synthro. They're on like 25 losartan, whatever it may be. And they're like, I'm getting really lightheaded when I stand up, or I'm getting this, or I'm getting that. And it's exactly what you're saying. Like they're treating what's on their arm after they walked through the lobby, after they had their coffee this morning, after they got a little bit nervous because the doctor read their weight to them, and they're treating that pressure, and they're not actually getting an accurate reading of what their
if you're not doing 24-hour ABMs, you don't know what the pressure is. Again, I'm a big proponent in 24-hour ABMs because I need to know what you're doing at night. Because if you're not physiologically dipping, then you're sleeping hypertensive, or your RAS system, your renin-angiotensin aldosterone system, is going through the roof. So you're sleeping hypertensive. You're waking up hypertensive with a rush in cortisol, and you wonder why you have a heart attack. But again, if you're not dipping into the low 100s over 70s or 60s, you're sleeping hypertensive. So that's why I always make sure my people are pretty much taking the, whether it's their ARB or ACE, depending on what we're using, I want them on it twice a day. What the hell do I want at 6 o'clock in the morning? The goddamn thing is going to wear off by 3:30, 4 o'clock. So then you got another 12 hours of hypertension going on. Morning, evening, morning, evening. Balance out the blood pressure. You see that all the time. Like you talked about, like losartan. I see that all the time. And I'm like, pressure's still high? Yeah. I said, because you got a security guard blocking your receptor. You don't have a police officer. Losartan's got a weak affinity for the angiotensin 1 receptor. Use omelsartan. Use telmelsartan. Oh, it's too expensive. We're not using that. Okay. Well, use losartan and then add metoprolol, HCTZ, but give them Viagra, Cialis, and hormone replacement therapy. Either way, I'm going to make my money because I'm going to let you screw it up and they're going to come to me, or you can just listen to me and we don't have to fix it.
Exactly.
So, Dr. Jason, I got to ask, you have a lot of services on your website. What's one of your favorite things to do for men?
Men?
Like one of your favorite men's health services?
Hormone replacement, erectile dysfunction.
Yeah, I can imagine that you really get a lot of good results, and giving guys like their sex drive back is probably got to be super influential on them. I mean, we put so much emphasis on just the ability to get an erection as a man.
Oh yeah, 100%. And that's
you're changing the course of their life.
Mm-hmm. Because it's funny, it's getting better now. But see, like I said, I'm in a buckle shirt, and I don't dress up when I dress like a normal person when I go to work. So I tell people, and then exactly like how we're talking now. This is how I talk with my patients. So the relaxation comes in. But I always ask my men right off the rip if they're saying, hey, hormones, and I'm like, well, let's talk about the big elephant in the room. How's your erection compared to 10 years ago? Because I'm waiting for the answer. When they tell me yes, I'm like, you're full of shit. Now let's go ahead and answer truthfully. Well, okay, there you go. Thank you. Now let's solve the problem. What's going on? Because if, you have to look at it from an erection and a drive and libido state, right? Because a lot of your doctors, here's your testosterone, Cialis, Viagra, here you go, have good fun. Well, say I give you testosterone, but your drive isn't that high anymore, right? But your testosterone's 1,000. Okay, well, damn, that doesn't make sense. I can get an erection, but I can't maintain erection, but I don't have a lot of drive. Well, think about it. You know this as well as I do, guys. In America, what we're sympathetic driven, right? We're cortisol driven. We're in pregnenolone steal probably 90% of the day. So guess what we're down regulating? Dopamine, our caveman brain. So your testosterone's 1,000, but your dopamine's in the shitter. So you have no drive. So I use a lot of cabergoline and apomorphine to calm people's sympathetics down, but to raise dopamine. You start adding those two things into one or two of those things in a mix with testosterone, now you're starting to let fire from a drive perspective. But then you have to, again, same difference with erection. We weren't taught a lot that in school. So what is it? PDE5 inhibitors. PDE5 inhibitor. That's what you give. Well, hold on. Is it a flow? Is it a hormone? Is it structure function, right? Because if it's libido, like I said, we work on hormones. Okay, we solve libido, but I still can't quite, I can obtain, but I can't maintain. All right, well, let's get a little flow in there. Okay, I gave you some daily of Cialis and then Viagra when needed, but you're still not there. Okay, well, it's structure function. Now we got to come back to the erectile tissue and start working on that. So that's where we come in with PRP, stem cells, Botox, medical grade penis pumps. Now, I tell people, when's the last time you worked out your penis? Sex, masturbation don't count. They're like, what are you talking about? Thank you. When we work out, what happens? Our arms swell, the veins get bigger, vasculature gets bigger. I said, then if your penis is kind of like a muscle with blood flow, why wouldn't we do the same thing? And they, you got to break the taboo. I said, start using these pumps that I recommend. Let me know how you're doing in about 6 months. They come back like, holy shit, this is the best thing I've ever done in my life. Every morning, get up before you have your cup of coffee, go in the bathroom, use your pump, be done with it. Next thing you know, within 2 or 3 months, your resting state looks a whole lot more healthier. Your erect state is better. The ability to hold the erection is better. You follow what I'm saying? So that's what I pride myself on, is being able to look at, okay, you're on hormones, you're on ED drugs, time out. It's a structure function problem. It's not a structure function problem. It's a libido problem. You got to know where to go, because if not, it's going to be hormones, Cialis, Viagra. Shit, it didn't work. You see what I'm saying?
Oh yeah.
Come back to that. But yeah, we just had a guy. I work with another gentleman. He does a lot of my ED treatment. I'm the one who does the medical side of stuff. But we just took a guy about a month ago who hasn't had an erection in 18 months after his second treatment. For the first time in almost 2 years, he was able to have intercourse for longer than 5 minutes with his wife. And he's like 65, 70. See, that's gold. You won all day with that.
That's awesome. So basically go visit Dr. Jason and you will be punching holes in the drywall.
Yes, you have to. And again, you know what's nice though? Really, at the end of the day, I tell my guys, there's nothing that's going to go into you that I haven't done myself. So I'm not, the drug rep didn't tell me, I didn't go to a conference. I'm your guinea pig. I'm a scientist. So I'm like, just give this a shot. I tell my wife, like when I first started using NAD and pushing it IV straight, I'm like, well, my colleagues told me that this is going to hurt. And once I realize I'm not going to die, it's the best thing ever. I said, so watch me. And if I die, then don't give anybody NAD. You know what I'm saying? So I'm always experimenting with different things. And if it works, I pass it on. And see, I think that's what happens too when you build trust with your patients. They're like, well, doc does it. All right, then cool. I'm going to do it too. So.
Yeah, I mean, to a degree, you're a representative of health. And if they look at you and say, all right, I mean, I remember being in a cardio pharmacy one time and this dude probably weighed like 600 pounds and he's teaching people about heart health. And I'm like, not sure you're the guy.
Yeah. I mean, don't get me wrong. It helps. Like you said, it helps to at least look the part. I think, again, it doesn't matter. We're still what? You got everybody has their 10-second elevator speech. You got a very minimal time to make a first impression. So however you have to do it, that's fine. That's what for me, it depends on where I have to be and what I have to do. I have to put an Armani suit on, or to kind of just wear a t-shirt. All I need is to break the door. Then I can win. I just got to get in the door. You know what I'm saying? The same thing with them. If they can just break down, feel comfortable, then you got them all day. And you can make that change, though. You can show them, hey, doc does it, his staff does it. Cool. All right. Then I'm missing out. It makes them, they want this now. Well, man, this is doing good. That's like during COVID. We treated COVID. I think one person in my entire staff got COVID the whole time COVID was going around. Because we were doing everything from ivermectin, hydroxychloroquine, methylene blue, thymosin alpha-1, TB500, IVs every week. I was probably pissing green. I was so immune strong, but I remember I had to do a cardiac arrest with a guy, full-blown COVID, right? I'm like, oh, guess I'm going to get it. Never got it. Still to this day, never gotten it. And seen over 20,000 patients during that period of time. Still haven't got it. Because what? We boosted the immune system. What, again, virus, cancer, bacteria, parasites, what are they? They're opportunistic. The lion going after the wounded hyena. So guess what? Load yourself up with the army and nobody's going to attack you. If you're not taking the high doses of C, of course, all these different things. My regimen every day is full. I don't get sick. I stay sharp, so. But it was funny, like with the COVID, I mean, there was literally nobody would write for hydroxychloroquine or ivermectin in my area. I probably would have to say within at least 100 to 150 square miles. My poor office, my girls were getting 400 to 500 phone calls a day because I knew what and I didn't write it haphazardly. I know the research and I know what it was doing. It wasn't just like, oh, this is cool, let's write it. So I made them make appointments. But yeah, we get 400 or 500 calls a day for that medication.
Wow.
It was crazy. It was so crazy. I mean, that's because I opened in 2018, then COVID hits in 20. I'm like, great, here we go. This is going to take a shitter. But you know what we did though? We changed our script. Yes, I do regenerative medicine and this, I guess maybe higher end or more scientific based medicine, but I still know how to take care of a sniffle, sneeze, cold, cough. A lot of doctors in my town shut their doors. We put an ad out. Give me $65. We'll sign you up. We'll take care. We will transfer your care to our care for $65, primary care, no questions asked. And then when your doctor comes back, you're more than welcome to leave. But we want to make sure you still have someone to go to. And you know what happened? Nobody left. They all stayed. Because when it was bad, we never closed our doors. Their doctors left. We didn't. And so there we go. And then after the first month of COVID, it just light years exponentially grew. So
wow, that's definitely a big thing, that trust model right there. Because when COVID started, and as you're saying, a lot of the offices were closing up, like patients, they lost their trust in their doctors, and then they got into a huge panic. And then to be able to find, they were frantically looking for somebody to do anything for diabetes, heart stuff, chronic conditions. They were looking for anybody there because their doctor couldn't be called upon, couldn't be located on there. So being able to find somebody open, I'm sure it meant more than the world to them.
Yeah, because we did, like I said, and the staff, and we kept plugging and chugging, and we did good. But that's where the regenerative model comes in. That's where I guess basically metabolic medicine, that cellular level, using things that people don't use.
That's pretty interesting stuff. I mean, just the journey that you've been on and the ability to take control of, how you see healthcare and are able to implement those techniques is pretty interesting stuff. And it's pretty inspirational too, just because a lot of people won't take that jump. They'll get out of med school, they'll get out of farm school, whatever, and they'll go just to do, whatever they're. Yeah. I mean, like a bunch of people in our class, like Cam and I didn't go to residency. We wanted to go do our own thing, and a bunch of people in our class, like, oh, you have to do residency. Or everybody, professors, the whole school is like, if you don't do residency, whatever. I'm not going to get into it. Yeah. And it's like
there's a lot more to healthcare than just.
And the thing is like, we're pharmacists. We have some of the best training that you can possibly get.
Yeah.
Like to understand the drugs that people get on, to understand the interactions and a lot of the profiles. And then on top of that, we have doctorate level knowledge of
100%
body functions. And, I hate to say it, we advocate for the profession of pharmacy a lot on here too, just because it's our career, but
of course
we have so much training. And then I almost feel like pharmacists a lot of times are like the redheaded stepchild of medicine. It's like you're in a hospital. Hey, you're just checking kidney function and whatever, anti-coag, vanco levels. No offense to any hospital pharmacists out there. You know what I mean? But like you go to retail and then you just have a bunch of patients yelling at you and you've got like docs up your butt. Cam, is more experienced with that than I
I'll say you don't have any
am.
docs up your butt. You just have patients yelling about Adderall.
Yeah, I want Adderall. Again, at 45 years old, you didn't just get a diagnosis of ADHD. You want the amphetamine. Just be honest with me and tell me you want the legal amphetamine, and I'd have more respect for you. But don't tell me, because when I tell them, like, okay, well, you think you're having difficulty concentrating? Let's go ahead and do Provigil or modafinil. I love the drug. It's going to keep you hyper-focused, but you're not really going to get the jitters. No, I don't want that. Oh, but I thought you were a businessman. I thought you wanted to stay hyper-focused so you can solve complex tasks. Oh, you just want amphetamines. Never mind. I'm sorry, my fault. But like you guys said, I get, you are right. And that's what, it's just terrible the way they do things. It's like, with you guys, pharmacists thinking outside the box, again, that's where you're a resource to me. That's not what I went to school for. But what happens, I think you said, you get your cookie cutter pharmacist to go work at Walgreens. You're not even using your brain anymore. Take the pills. You do it. It's like counting money. Shovel it into there, make the sticker, give it out. Do you even know what you just did? You know what I'm saying? And then the like you said, the computers will pull up the red flag. Hey, this person's on leothyronine and levothyroxine. Hold on, here's a red flag. You know what I'm saying? But why are people ostracized? Again, medicine to me is always, again, I love it. I'm trying to change my own little path. But to me, it's nothing more than a swinging ego contest. Because what is it? If you're a DO, you weren't good enough to be an MD. If you're a PA, you weren't good enough to be an MD. If you're an NP, you're just a nurse. If you're a chiropractor, you're not really a doctor. It's like, what? Stop. If we could all come and just work and, appreciate everybody's knowledge for what they do, our patients would be better. But it's always got, oh, well, they don't know. Or that's just a dumb nurse practitioner. Or that's just a dumb this or that. Hold on. Like I said, I'll take you guys any day against most medical doctors or DOs or any providers in biochemistry. Everyone blows it off in college. Probably one of the most important classes you're ever going to take if you want to know about the human body. And you guys take more of it than anybody else. We take one semester of it. Right?
Oh, yeah,
but I want to have the doctor argue me about biochemistry. You can't even tell me what glycolysis is and break down ATP and tell you how much you get out of it. You don't even fucking know. So shut up.
Amen.
Amen. Hey, Dr. Jason, man, I got to say, this has been an absolute pleasure having you on. We are going to have to do it again soon.
This was fun.
We like talking about men's health. We like giving people different options. We are firm believers, like there's no one right way. And I think that aligns a lot with your ideals.
Yes,
there's no one right way to make stuff happen. And really the goal here is to give guys options. Hey, maybe this doesn't work for you, but maybe this does. And if it's out there, it's a beautiful thing, because seeing guys specifically get healthier, take care of themselves, and really start giving a shit about themselves, filling their cup so that they can continue to take it out in the world and give to the people that they love is really our goal. So thank you so much.
Again, it's my honor to be on, and I really appreciate you having me on, and I'd love to do it again.
Oh yeah, we appreciate it. So you're talking about breaking down the doors. Where can our listeners and our followers break down the door to find you?
So I'm in Port Orange, Florida, which is Daytona Beach area. They can go on to our website, www.anti-agingdocs.com. That's really where everything is. That's all our services, everything we do. And if they want, they can come to Port Orange, meet me, and then they can become a patient. We can also do televisit, but I want to always see my patients initially first. So I want to always touch and see them, because if not, I don't even know who I'm talking to. I want that relationship with my patients. But that's where they can get the information, and that's where we're located.
Awesome. Well, we'll definitely talk to you soon.
Yes, sir. Thank you guys so much, guys. I really appreciate it. Thank you.